Hello, everybody. This is Chris Kane from UC San Diego. So we're going to talk about the ways in which our practice environments can support each other and coordinate care for the betterment of urologic patients and the community. And so I'll start by just talking a little bit about academic urology, and I think the niche that we play and the opportunity to coordinate that we play. So I'll talk a little bit about UC San Diego, but I think some of the summaries that I give are similar to large academic medical centers. So we're part of the University of California system, a large public university system. We think the best in the country and the best in the world. We produce about a third of all the bachelor's degrees in California. We have about 1.8 million living alumni, 61 Nobel laureates, and contribute over $46 billion to the California economy. Concerning our health centers, we have 5 UC medical centers. You know them well: UC Davis, UC San Francisco, UCLA, UC Irvine, and UC San Diego. And together we perform about half of all the transplant surgeries in California. And if I showed you a list of major tertiary things such as bone marrow transplants, solid organ transplants, we would have the highest volume of the most tertiary and highest risk procedures in the state. About 60% of our patients are on Medicare, Medi-Cal, or lack insurance. So that's a real challenge for us from an economic perspective, but it's also a responsibility that we take very seriously. Of course, we have all 3 missions: the traditional missions of teaching and research and clinical care, and that's coordinated through translational medicine. And the translational medicine where it really hits patients is clinical trials, which I'll speak about in a moment. Our research mission is very well funded. We have about $1.2 billion in research grants. About 680 million of those are in health sciences. So health sciences is dominant in terms of a grant funding for the entire campus. We break our enterprise into our academic enterprise, which includes our School of Medicine, School of Pharmacy, soon a new School of Public Health, and then the clinical enterprise that I have a role helping to lead. When we think about our academic output, it's quite remarkable. This is one measure. This is the 2018 Nature Index. The size of the dot is the size of our contribution to science. And you can see that UC San Diego ranks 5th nationally and 8th globally. So that large dot, the United States, of course, has the largest scientific impact of any country. These dots around the edge are the size of the relative size of the economic impact, scientific impact contributed by the various countries. And then you see UC San Diego inside the US dot as the 5th most significant national contribution. And our School of Medicine is large, and I put this summary to show that we have over 1,500 faculty, 500 medical students. We have 25 residency programs, 6 of them top ranked, including urology, and we train 935 fellows and residents. So the education mission is enormous, and we take it very seriously. And the care we provide, we believe, is world-class. It's heavily focused on tertiary and quaternary care. We have over 9,000 health employees, about 800 beds across 2 hospitals. And you see the statistics in terms of admissions and ambulatory visits. And it's now about a $1.7 billion operation. I mentioned translational medicine. We think clinical trials, particularly in oncology care, is the best care that patients can receive. We have about 7,000 patients in active treatment on therapeutic clinical trials. So our clinical trial infrastructure is very significant. And this is my last slide and probably the most significant. And when we focus on how we can coordinate and support each other, this is really where we bring something special to the table. When we think about our subspecialty care in pediatrics, urologic cancer, stone disease, women's pelvic medicine, infertility, and reconstructive urology, we're not just talking about recruiting fellowship trained faculty. We're often talking about really multi-specialty coordinated care. Our oncology team includes radiation oncologists, specific GU pathologists, GU radiologists. So we have this ability to assemble multidisciplinary teams in academic medicine that really is challenging to do in a private hospital system or in a LUGPA. And I think that provides, of course, great training, but it also provides great care and an opportunity for the most complex care to be well coordinated. We also train your future urologists. We're a wonderful opportunity to coordinate with so that residents, when they finish their training, could potentially stay in the community. And they're going to want to interview with Eugene at Kaiser, and they're going to want to interview with Ed to see if there's an opportunity to stay in one of the clinical practices in San Diego. We graduate 3 residents a year and 5 fellows a year. We can also recruit jointly, as Ed and I have done. Because people are attracted to coming to academic medicine, sometimes we can use that ease of recruitment to fulfill opportunities that have arisen with Genesis. And why is that good for us? Well, it's good for us because it gets us closer to potentially our partners who refer their tertiary and quaternary care patients to us. And we acknowledge that much care will occur very well inside the Genesis practices. So we think having a close relationship actually helps us from a referral perspective, but I think it also helps patients be cared for in a setting that might be more convenient for them, and it might be closer to where they live and work, as Ed has practices all across San Diego County. We also want to support our community urologists. I view that we have 2 sets of customers. We have the patients who we're caring for, but we also have our urologists in the community. And when they need defense and they're being attacked either medical legally or otherwise, where it's possible to do so, we'll defend them. We also want to provide professional support, letters, board support letters, things like that. We also, of course, provide CME with grand rounds and CME courses. And Ed and I have an opportunity to be in a clinically integrated network. And that's where we can actually offer improved contracts with payers in exchange for working on quality projects. So there's a lot of ways to coordinate care that I think mutually supports our practices, mutually supports each of our needs. It just requires honest conversations about the zones where we might be competing and the zones where we can support each other. And so I think that we view that we have a unique place and role to play in our community, but we respect the role of other integrated health systems and large urology practice groups as well. Thank you.